Hello, future RMTs. Welcome to our classroom. And in this lecture, what we're going to discuss is all about serous fluids. Our learning outcomes are as follows. Describe the formation and function of serous fluids. Differentiate between a transudate and exudate, including the etiology, appearance, and its laboratory test. And relate laboratory test results to transudate and exudate effusion. Okay, when we said serous fluids, that's actually, guys, a combination or a general term for pericardial, peritoneal, and pleural fluid. And when we said serous fluids, no, these are the fluids that can be found between the parietal and the visceral membranes. And when we said parietal, it means that this is a layer of membranes that lines the wall of the body cavity. And actually, it comes from the word pariet, which means a cavity wall or a cavity wall. And when we said visceral, that is actually a inner layer that covers the viscera or that covers the organ, and that is your visceral membrane. So we can say that these serous fluids, the pericardial, peritoneal, and pleural fluid, are the fluid that gives lubrication. No? It provides lubrication to the two membranes so that it will not cause trauma to the organ. Okay, so that the it will not move against each other. Okay, and that is the major function of serous fluids, whether as it is a peritoneal, pericardial, or pleural fluid. Okay, we have what we call diffusion, and when we say diffusion, that's actually, guys, an accumulation of the fluid between the membranes. Okay, the accumulation of the fluid between the membranes is what we call our effusion. Okay, that is what we call our effusion. And I want you to remember that this accumulation of fluid in the membrane is possible through different conditions. Okay, and this effusion can be through damage, or there is a inflammation or an infection which lead, no, into a increase in accumulation of the fluid in the tissue, okay, which is referred as the effusion. And when we say diffusion, that is categorized or classified as transudate or exudate. So what is the difference between an exudate transfusion, between exudate and transudate effusion? Okay, so take note, guys, when we said transudate, that is a type of effusion which is caused by systemic disorder that disrupt the fluid production and regulation between the membranes. That is actually a transudate is more on the damage, more on pressure. Okay? More on pressure kapag sinabi nating transudate. And this pressure is due to the systemic disorders. Usually, conditions that can trigger effusion related to transudate is hypoproteinemia, congestive heart failure, and nephrotic syndrome. These are the cases wherein the patient experienced transudate, meaning to say those patients with renal problem who developed effusion, no, is more on a transudate due to systemic disorder, okay, that disrupts, no, the fluid production and regulation of the membrane. While when we said exudate, that is a type of effusion that is caused by damage to the membrane. And this damage can be due to infection, malignancy, or inflammation. So ibig sabihin, if you are having a malignant tumor, you are most probably will develop an effusion related to what we call exudate. There are laboratory tests, several laboratory tests that will help us to identify whether it is a transudate or an exudate. Take note, guys, that a transudate effusion appears clear, while an exudate transfusion or effusion rather appears cloudy. If we are going to discuss the transudate or the fluid, the serous fluid serum protein ratio, okay, if the result is less than 0.5, then it means that it is a transudate. Okay? If the result is greater than 0.5, it means that it is a exudate. Now remember guys that exudate is usually seen in hypoproteinemia. Okay? Next is if we're going to discuss the lactate dehydrogenase versus the serum and the fluid lactate dehydrogenase ratio, and if the result is less than 0.6, that is a transudate. If the result is greater than 0.6, that is exudate. Actually, uh, there's there's a simple way to remember whether it is a transudate or exudate. If the results are all less than no 0.5, 0.6, less than 1000, less than 45 to 60, less than 0.3, less than 0.6, but greater than 1.1, that means it is a transudate, and the rest is greater than. And another possible or another way to differentiate it is a spontaneous clotting. No, transudate does not clot. Exudate clots. That's why in the succeeding slides, no, we have the Rivalta's test, and that Rivalta's test will help us to identify whether it is a transudate or exudate. Later, I'm going to discuss that. Okay, take note, guys, that spontaneous clotting is possible in transudate, while spontaneous clotting, no, 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 I'm sorry, spontaneous clotting is not possible in transudate, while in exudate it is possible. Okay. Next is glucose is decreased in transudate while increase in exudate. Okay. So yeah, this is what I'm telling a while ago, the Rivalta's test. Okay. In Rivalta's test, uh, exudate is positive. No, there will be a heavy precipitation. Okay, that heavy precipitation is an indication of the fluid is a exudate. Okay, so this is what I'm telling a while ago. The Rivalta's test, no, where we're going to have acetic acid and water. Well, actually, it's like distilled water and an unknown fluid, that is the fluid. And if there is a heavy precipitation, that is your exudate. No, the absence of precipitation is your transudate. Now, what are the three methods of collection? Again, take note that a normal appearance of your serous fluid appears clear to pale yellow. Okay? So, pleural fluid is torosynthesis, pericardial fluid is pericardiocentesis, and peritoneal fluid is paracentesis. Remember guys, know that peritoneal fluid, okay, is also known as the ascites. Okay, don't be confused. If the nurse will tell you, okay, this is the ascite fluid of my patient, of our patient in station 5. Okay, don't be shocked or don't be amazed if if the nurse told you that that is the ascites. Well, actually, ascites is similar to your peritoneal fluid. Okay, so these are the method of collection: peritoneal, paracentesis, pericardiocentesis, and pleural is tomosynthesis. Of all these methods of collection, I want you to remember that pericardial fluid is the least body fluid that is aspirated. Okay, why? Kasi siya yung pinaka-least, siya yung pinaka-seldom, or we can say rare to aspirate. Because the pericardial fluid is the fluid in the pericardium, no? Or in the pericardial cavity that provides caution, provides lubrication to our heart. And too deep. no? Yung sobrang lalim na insertion ng needle might injured or injure our heart, which can cause damage into the cardiac tissue. That's why pericardial aspiration or pericardiocentesis is classified as a crucial laboratory procedure or a crucial uh, procedure in the hospital. No? Well, of course, all procedures are considered to be done with utmost uh, uh, utmost confidence na gagawin. But pericardial is very dangerous because you might damage the heart if sobrang lalim ng iyong puso. Okay? So, the methods of collections or our TPs can also or is also collected in three different tubes for chemistry, for hematology, for your uh, microbiology section. Okay? But usually, ang madalas, most commonly, is for cell count. Okay, for cell count. But the three tubes must be collected. Not the same thing with CSF. Tatlo pa din yan. And take care because you might interchange pleural from peritoneal. That is common. The submitted fluid is peritoneal, but the technologist referred it as pleural. Well, there's nothing wrong with that. Anyway, the same test will be done, the same chemistry test, the same hematology test, the same microbiology test. But the integrity of the laboratory is being compromised because instead of reporting pleural fluid, you said that is a peritoneal fluid. Please make sure that if you are going to process this type of body fluid, you are aware of what body fluid you are processing. Okay? So for EDTA, cell counts and differential counts. For sterile heparin, that will be used for microbiology and cytology. For plain or for chemistry, you can use plain or heparin tube. Okay, so again, take note guys, that you have to collect your peritoneal, pericardial, and pleural fluid into three different collection tubes. Okay, so this is our pleural fluid. Again, when we said pleural fluid, that is the fluid that can be seen in the pleural cavity, okay, in the heart, in the lung. No? Remember that a clear pale yellow is the normal color or appearance of our pleural fluid. Take note that turbidity or white discoloration in your pleural fluid is an indication of microbial infection, and that is usually your tuberculosis. Okay? Usually, tuberculosis, okay, that is caused by Mycobacterium tuberculosis. If the pleural fluid appears brown, it means that there is what we call the rupture of amoebic liver abscess, ALA, if you still remember that. Now, you might wonder, that is a amoebic liver abscess. Why is it? Why is it found in the pleural cavity, not in the peritoneal cavity? Well, actually, pwede rin naman sa peritoneal cavity. Okay? But since our liver is near the lungs, near the pericardial space or the pleural space, no? Yung effusion, dun siya napupunta. Okay? Now, if the pleural fluid appears black, it is due to fungal infection, which is true with aspergillosis. If the pleural fluid appears viscous, it is correlated to malignant mesothelioma. Milky pleural fluid is chylous, pseudocylous material, or pseudocylous material, okay, which will be differentiated in the next slide. And a pleural cavity that is bloody may be due to hemothorax or hemorrhagic effusion, which is somehow self-explanatory if you still remember your if you still remember your traumatic and your hemorrhagic or intracranial hemorrhage. Okay, so like what I said, we're going to differentiate chylous material from pseudocylous material and hemothorax from hemorrhagic effusion. Okay, remember, a pleural cavity that appears milky is due to chylous or pseudochylous. What do we mean by chylous? A chylous fluid or a chylous pleural fluid is due to thoracic duct leakage. I repeat, when we said chylous, that is due to thoracic duct leakage. More or less, we can say that chylous pleural fluid is due or a chylous pleural fluid, since there is a thoracic duct leakage, a damage, which means damage, kanina, sabi natin, kapag damage, no, pwedeng siya ay, leakage, no, damage, no? Bakit nagkakameron ng leakage? Because of increase in pressure. Okay? Now, for pseudocylus, no, a chronic inflammation exudate. Alright? Now, appearance, milky, well, of course, milky, white, that's the pleural fluid. For pseudocylus, it can have a green tinge or a gold paint. What is the indication of green tinge? The indication of green tinge is actually your inflammation, or infection. Leukocytes increased lymphocyte in chylus, while for pseudocylus, mixed cells, predominantly neutrophils. Cholesterol crystals is absent in chylus, while in pseudocylus it is present. Triglycerides greater than 110 in your chylus, but less than 50 in pseudocylus. Sudan stain is weak for chylus, weak for pseudocylus, and positive 3+ for chylus. Now, how about for pleural cavity that appears bloody? Okay, blood distribution uneven for effusion or hemothorax effusion. Hemorrhagic effusion, even. Okay, so there is also another test to differentiate our hemothorax effusion from your hemorrhagic effusion. Okay, if the pleural fluid hematocrit is greater than whole blood hematocrit, that is your hemothorax effusion. If your pleural fluid hematocrit is less than your whole blood hematocrit, that is your hemorrhagic effusion. Or simply you can say, if greater than 50%, hemothorax. less than 50% hemorrhagic. Okay. Now, what are the significant cells that can be seen in our pleural cavity? Well, of course, we have your neutrophils, lymphocytes, mesothelial cells, plasma cells, and even your malignant cells. Okay. So when we said neutrophils, it is correlated or clinically significant with your pneumonia, pancreatitis, pulmonary infarction. For lymphocytes, tuberculosis, viral infection, autoimmune disorders, or malignancies. Mesothelial cells, normal or reactive forms, okay, have no significance. And mesothelial cells is usually decreased in tuberculosis. Well, for plasma cells, that is increased in tuberculosis or correlated in tuberculosis. And for malignant cells, no, malignant cells from the word itself, malignant cells that is seen or correlated or clinically significant with primary adenocarcinoma and small cells carcinoma. Okay, so these are the tumor markers that can be used for malignant of or effusion of malignant origin, which means no, which means cancers. Now remember, guys, when we said tumor markers, now tumor markers are not used for diagnosis of cancer, but tumor markers is used for the monitoring of the treatment and the possible recurrence of the cancer. Okay, so we have CEA, and CEA stands for carcinoembryonic antigen. That is for colon cancer. A tumor marker for colon cancer. CA125, ovarian cancer, and metastatic uterine cancer. Ano yung palatandaan namin sa CA125, yung 5, parang buntis. Ovarian. How about CA153, breast cancer, or even CA549 is also for breast cancer. CAR, CYRA rather, 21-1 is for lung cancer. What do we mean by CYRA? It means that your cytokeratin fragment. Okay? Cytokeratin fragment. These are your tumor markers for malignant effusions. Okay? Now, the significance of testing your pleural fluid. Now, if we have decrease in or glucose, no, that is decrease in rheumatoid inflammation or even in purulent infection. For lactate, well, of course, that is a what you call this, inverse relationship with your glucose. No? The greater the glucose is being metabolized, the higher the lactate level will it be, and lactate is increased in cases of bacterial infection. You all know that, no? You all know why is it like that. For triglycerides, that is decrease in chylous effusions, okay, and pH of your pleural fluid is decreased in cases of pneumonia that is not responding to antibiotics, decrease in cases of esophageal rupture, and decrease in cases of complicated parapneumonic effusion. Adenosine deaminase or ADA, no, is correlated in tuberculosis and malignancies. Well, for amylase, increase in pancreatitis, esophageal rupture, and malignancies. Okay, how about your pericardial fluid? Remember that a normal pericardial fluid appears clear pale yellow. Okay, a blood-streaked body fluid or a blood-streaked pericardial fluid is correlated with infection and malignancy. Usually, oh yan, nandiyan niluman, si bacterial endocarditis. That is the most common disease or the most common condition, no, that is seen kapag mayroong effusion in the pericardial fluid. And when we said bacterial endocarditis, that is your inflammation of the heart's inner lining, no? And that is what we call the endocardium. Okay? And the most common cause of endocarditis is no other than your bacterial infection. Okay? Again, increase in bacterial or increase in neutrophils is correlated with what we call bacterial endocarditis, which is the most common reason why we aspirate pericardial fluid. Aside from that, metastatic carcinoma, malignant cells. When we said metastatic, the the problem is not really on the heart. Nagmetastasize na. When we said metastasize, the cancer cells starts to invade other tissues. Kumakalat na. Metastatic carcinoma. Okay? So going back, a blood-streaked pericardial fluid is correlated with infection or malignancy. While for grossly bloody pericardial fluid, there is a problem in what we call cardiac pressure, or there is an overdose of anticoagulant medication. As you can see in the illustration that we have here, no, the pericardium that covers the heart, this is the normal appearance, no, the normal appearance of a heart covered by a pericardium. This is actually a build-up of body fluid in the pericardial cavity, no, in the pericardium. And this is usually referred, no, yung mga sinasabi ng mga na, na tinutubig yung puso, ito pulo. There is an effusion, a build-up of body fluid, of fluid in the cavity. And that is your pericardial fluid. You know, too much accumulation of fluid. This illustration shows an X-ray from a patient with your bacterial endocarditis, showing that the heart, you know, is being opaque. You know, and this opacity, you know, is an indication of the buildup of body fluid in the pericardium. Okay? So what are the significant tests for pericardial fluid? For exam stain and culture sensitivity, well, of course, that is for bacterial endocarditis, AFB, and adenosine deaminase, while is for tubercular effusion. Now, how about for peritoneal fluid? Oh, this is what I've told you a while ago, that peritoneal fluid is also known as the ascites. Again, it appears as clear, pale yellow as a normal color or a normal appearance, and a turbid ascites or a turbid peritoneal fluid is correlated with microbial infection. Bakit nagiging turbid? So why is it that a peritoneal fluid becomes turbid in cases of bacterial infection or microbial infection? Because of the multiplication of the microorganism in the fluid. Green appearance of your peritoneal fluid is an indication of gallbladder and pancreatic disorders. Okay? A blood-streaked body fluid or a blood-streaked peritoneal fluid is correlated with trauma, infection, and even malignancy. While for a milky peritoneal fluid, that is correlated with lymphatic trauma and blockage. Okay? So, for the cell count, no, less than 500 cells is considered normal. While if there are greater than 500 cells per microliter of our peritoneal fluid, it means that that is an indication of a bacterial peritonitis or even cirrhosis. Cirrhosis in the liver. No? Cirrhosis is a scar in the liver that can cause alteration in the liver function. Okay? So increased neutrophils is an indication of bacterial peritonitis, and malignant cells is for, of course, for malignant disease. As you can see in this illustration, no, this is not a Langgonisa. This one, yeah. This one is not a Langgonisa, but this is your small intestine. This fluid is not a river nor a lawa, no, or lake. This is your peritoneal fluid. Okay? As you can see in this illustration naman, okay, there is a malaking tummy, no? And parang puputok na siya, parang buntis, that's not a pregnant, no? But actually, bakit siya gumaganan? Is because of the build-up of body fluid. And as you can see in the color of the skin, no, nagiging yellowish po ang color ng skin, and that is to be a person with a problem in the liver, which can be, I am not saying that is the final, which can be due to cirrhosis. Okay, that's why there's a buildup of bilirubin that causes a yellow discoloration. And as you can see here, meron namang drainage. Bakit dinidrain? Because of accumulation of the fluid. Usually, yung pong mga inoperahan, no? Sa mga gallstones, sa mga pancreas, sa mga lapay nila, okay? Nakakameron ng drainage of the fluid, okay? And that is true with peritoneal fluid. Ganun yung nangyayari. Kagaya po nito, na meron silang mga body bag na nakalagay to drainage or no, to drain the fluid in the peritoneal cavity. Okay, so these are the tests, the significant tests for our peritoneal cavity. Peritoneal lavage, no? When you said peritoneal lavage, the cell count greater than 100,000 RBCs per UL is an indication of blunt trauma. CEA or carcinoembryonic antigen, malignancy of the GI. When I said GI, that is your gastrointestinal tract. This is what I've mentioned a while ago, CA125, malignancy of the ovarian origin. No? Decreased glucose in tubercular peritonitis and malignancies. Amylase, increase in pancreatitis. Bakit increase ang amylase? Because there's a problem in the pancreas. No? And amylase is a pancreatic enzyme. Remember guys that if there is a problem in the tissue where the enzyme is produced, it will increase dramatically. No? Increase in the levels of an enzyme is an indication of a damage in the cells. BUN creatinine is indication of ruptured or punctured bladder if BUN and creatinine is increased. GSCS, gram stain and culture sensitivity, well, of course, that is indication of bacterial peritonitis. While for AFB and ADA, that's still no for our tubercular peritonitis. Tubercular caused by Mycobacterium tuberculosis. Remember, guys, that Mycobacterium tuberculosis can't be distinguished from a simple gram stain because the cells of your Mycobacterium tuberculosis, will not have an affinity with our gram staining. That's why we are using acid-fast stain or acid-fast bacilli stain. Okay, and these are our pasoma bodies. No, these are the malignancies in the cells that can be seen in benign condition or even associated with ovarian and thyroid carcinomas. Okay, again, pasoma bodies are certain concentric striations of the collagen-like material, and that is seen usually in benign condition, but can also be seen in cases of ovarian and thyroid carcinomas. And that is our discussion about pleural, peritoneal, and pericardial fluid. We'll have our reinforcement lecture as scheduled to strengthen the information or to strengthen your knowledge about these body fluids. Thank you and stay safe.